Schizophrenia is one of the most severe of the mental health disorders and the most common cause of psychosis. Schizophrenia is very devastating, and even though it affects just 1% of the adult population, it has a ripple effect that has an unstable impact on society. We walk by and around people in cities every day that suffer from schizophrenia. They might scare you at times or offend you in other ways, but after reviewing this chapter, attitudes and thoughts about these individuals may change. There are three categories of mental illness. Schizophrenia is a thought cognitive disorder. The other two are mood disorders and anxiety, stress-related disorders. Thought cognitive disorders affects the individuals through process, thinking, language, emotions, social behaviors, and ability to perceive reality accurately. Schizophrenia is derived from the Greek word schizo and means split, and phren, which means mind. Schizophrenia is a problem with the mind or thought. Somewhere in the individual's life, they have had an occurrence that caused a change. More than any other mental illness, schizophrenia probably causes more lengthy hospitalizations. Approximately 50% of the people hospitalized for mental illness has a diagnosis of schizophrenia. Since there are around 1.7 million people, adults, that have this disease, it contributes to family chaos because families are the ones that have to take care of these individuals. The cost to families and government is very expensive. Schizophrenia requires comprehensive treatment and multidisciplinary approach from healthcare workers and providers, such as nurses, social workers, occupational therapists, rehabilitation therapists, and family therapists. Schizophrenia is feared more than any other mental illness, probably because of the effects of the individual and the uncertainness of their actions. People who suffer from schizophrenia are 40 to 50% more likely to abuse substances than not. 75 to 85% of people with schizophrenia are dependent on nicotine. Mental illnesses that are more often than not coexistent with schizophrenia are depression and anxiety, panic disorders, and OCDs. And psychosis-induced polydipsia, which is a disorder that causes the individual to drink massive amounts of water, which can lead to water toxicity or severe hyponatremia, cerebral edema, and even death. Due to the comorbid depression and thought process that occurs with schizophrenia, these individuals are 20% more likely to commit suicide than the general population. Schizophrenia is thought to be caused by a combination of many factors, which include neurological factors known as the dopamine hypothesis. This is derived from the fact that antipsychotic drugs decrease dopamine and decrease symptoms of schizophrenia. Psychosocial or stress-related. Environmental factors show that the low socioeconomic class experience more symptoms, probably because of living in poverty, like congested housing, and they experience a lot of stress. Cultures interpret schizophrenia differently. What you and I might see as symptoms of schizophrenia, another culture may not see it as such. Example, visions or voices are an integral part of some religious experiences, which is important to their culture. But then on the other hand, these visions or voices in another setting would be considered abnormal. The person would be considered possessed. So it's important to assess cultural beliefs and experiences as well. In the last PowerPoint slide, I talked about some possible causes of schizophrenia. However, there are three things known and certain about schizophrenia, and that is, number one, first being the age of onset that it occurs. It almost always occurs in late adolescence or early adulthood. The second one is the role of stress in the individual's life. The onset and relapse is almost always related to stress. And third is the abnormal dopamine levels. The reason being is that drugs that block dopamine receptors are shown to be therapeutic. Schizophrenia is a severe mental illness that is chronic, treatable, but not curable, and the individual has impaired social competency. Some of the behaviors that are associated with schizophrenia include what you see in the slide above: loss of ego boundaries, inability to trust, they may be withdrawn, they have love-hate feelings, confused, have chaotic thoughts, maybe represents autism. They have auditory hallucinations and delusions, hypersensitivity to sounds and sights and some smells. They may have difficulty relating to others. They're very negative. They lack social awareness, and they are very disorganized. We'll talk about some of these behaviors in more detail a little later. The course for schizophrenia usually includes recurrent acute exacerbations of psychosis. Just like physical diseases, mental illness has good times and bad times. An example is a person with COPD has times when they are not having symptoms such as shortness of breath, and then there are times when the person with COPD cannot breathe. There are three phases to schizophrenia. The acute phase is when the patient is experiencing severe psychotic symptoms, positive and negative symptoms. During this phase, it is important to ensure patient safety and medical stabilization. Stabilization phase is the period when acute symptoms decrease in severity. Maintenance phase is the period in which symptoms are in remission, although there might be mild persistent symptoms. It is important that during the last two phases, stabilization and maintenance phase, that both patient and patient's family understand the importance of adhering to medication and participation in psychoeducational activities. This is to prevent or to avoid the acute phase. Preventing relapse can be more important than the risk of side effects from medications, because the side effects are reversible, whereas consequences of relapse may be irreversible. With each relapse of psychosis, there is an increase in residual dysfunction and deterioration. Symptoms of schizophrenia are grouped into four groups. These are positive symptoms, negative symptoms, cognitive symptoms, and mood symptoms. Negative symptoms of schizophrenia develop over a long time. These are the symptoms that most interfere with the individual's adjustment and ability to survive. The negative symptoms hinder the person's ability to maintain relationships, to maintain conversation, hold a job, make decisions, and maintain adequate hygiene and grooming. Changes in affect include a flat affect, which is no emotion displayed. Inappropriate affect, this is where the emotional response is incongruent to the situation. Blunted affect, which is minimal emotional response, and bizarre affect, which is characterized by facial grimacing, giggling, or mumbling to oneself. Anhedonia is a diminished ability to experience pleasure or intimacy. Alogia is a deficit in speech and the content of speech. Inertia, which is a lack of energy, lack of persistence, and lack of self-care. Avolition means a lack of motivation and goals. The prognosis for exhibiting negative symptoms are poor and compared to a good prognosis for those that only have the positive symptoms. The newer medication or second generation antipsychotics not only help stop the positive symptoms, but help good effects on lessening the negative symptoms as well. Neurocognitive and mood symptoms. Neurocognitive symptoms include impaired memory, disruption in social learning, and inability to solve problems. Mood symptoms include depression, suicidality, agitation, and anxiety. Positive symptoms of schizophrenia are referred to as extravagant psychotic symptoms. These are the ones that capture our attentions. These are the least important pragmatically and usually respond to medications. Positive symptoms include alterations in perception, which includes hallucinations that are sensory perceptions or impression without external stimuli, auditory hallucinations, hearing voices, visual hallucinations, seeing persons, gustatory and tactile is feeling bodily sensations. Command hallucinations command a person to hurt themselves or others. These are psychiatric emergencies. With auditory hallucinations, you may see the person turning as if talking with someone that is not present, or frequent eye blinking. Alterations in thinking include delusions, which is false fixed beliefs that cannot be connected by reasoning. Also, ideas of reference, persecution, which is feelings that others are out to get or plotting against them. Grandiosity, feelings of importance and power over others. Somatic sensations, which are delusions that are fixed on an irrational beliefs about his or her body. Their concrete thinking is impaired, and an impairment in the ability to use abstract concepts. An example is you may ask the client what brought you to the hospital, in the hopes that the client will say feelings of anxiety or whatever it may be. But instead, they might reply, the cab. Their ability to use abstract thinking is absent. Alterations in speech include clang associations. This is rhyming words in a sentence that make no sense. An example is the client may state, see the night, it is time for fight, what about right? The words rhyme but have no meaning. Neologisms are words invented by the client that are meaningful only to that person. These are words that are just made up. Word salad is just a bunch of meaningless words to the person listening. Thought broadcasting is when the individual has the delusional belief that others can hear his or her thoughts. Thought insertion is when the individual has the delusional belief that others have the ability to put thoughts in a person's mind against the person's will. Alterations in behavior include extreme motor agitation, stereotyped behaviors, automatic obedience, waxy flexibility, stupor, and negativism. The first generation psychotropics have been useful for abating the positive symptoms of schizophrenia, just not effective for the negative symptoms. Paranoia is characterized by intense belief that others are out to get them. The patient may be hostile, suspicious, and aggressive. No matter what the paranoia ideas are, they cannot be corrected by experiences or modified by facts or reality. Their most used defense mechanism is projection. In other words, they project their feelings onto other people. One characteristic seen with paranoia is ideas of reference. The person misinterprets messages from others. An example being two nurses are talking and the individual feels that they are talking or plotting against him or her. Also common to paranoia are auditory hallucinations, someone or something telling them to do things which could be harmful to themselves or others, and delusions, such as delusions of grandeur. They feel like they are, or believe they are the president, they are Jesus, the Shah of Iran, or and so forth. Catatonia is an abnormal motor behavior. These individuals are the ones that have extreme motor agitation, either going nonstop to the point of exhaustion or retardation, cannot even feed or clothe themselves. They have a hard time carrying out basic ADLs. Other behaviors include posturing, which is holding an arm or another body part in a rigid position for long periods of time. This can result in physiological damage from decrease in blood flow if they're maybe holding their arms up above their head for a long period of time. Waxy flexibility is when the individual holds a position for a long period of time after being placed in an awkward position. That's how it gets its name, waxy flexibility. It's like the wax museum figures. Echolia is repeating the words of others. Example is, if I say, how are you today? They repeat, how are you today? And then I may say something else and they repeat it exactly the same. That can get very frustrating. Echopraxia is mimicking movement of another person. So if one person starts to march, the client with the illness may start to march and do the very same thing and turn at the same times. Catatonia is not seen as much today because of the many medications that diminish these symptoms. Disorganized schizophrenia is the most regressed and socially impaired of all types. A large number of these are homeless due to their regress and social impairment. They cannot interact with others. These individuals have lost contact with reality. Disorganized schizophrenia is characterized by looseness of associations, inappropriate and flat affect, bizarre mannerisms, incoherent speech, fragmented and poorly organized hallucinations and delusions, frequent giggling or grimacing in response to internal stimuli. These individuals neglect their personal appearance. Working with individuals with schizophrenia produces strong emotional reactions in most healthcare workers. These individuals are anxious, lonely, dependent, and distrustful. Therefore, these emotions evoke similar uncomfortable and frightening emotions in others. Once again, an extensive history is needed for assessment. Assessing for information about the patient's previous history with schizophrenia to establish a baseline functioning. Assessing whether the patient has had a medical workup, because some of the symptoms could be related to a medical or substance-induced psychosis rather than a true schizophrenic disorder. Assess possible dependence on alcohol or drugs. General appearance and psychomotor behavior. Observe for catatonia, unmoving, psychomotor retardation, general slowing of all movements, waxy flexibility, maintaining any position placed in, even if awkward or uncomfortable, pacing and hyperexcitability. Observe for lack of physiological self-care, inattention to hygiene and grooming, failing to recognize their own sensations such as hunger or thirst, which can result in malnourishment and constipation. Occasionally, they develop eidexia, excessive water intake that can lead to water intoxication and hyponatremia. Assess sensorium and intellectual perceptions such as hallucinations, which are false sensory perceptions, or perceptual experiences that do not exist in reality. These can involve all the senses. Ask if the voices are telling them to hurt or to harm themselves or anyone else. Assess contents of thought, delusions, fixed and false beliefs that have no basis in reality. They may suddenly stop talking in the middle of a sentence as if listening to someone. Word salad, jumbled words and phrases that are disconnected. Echolia, imitating the words of the nurse or someone else's words. Flight of ideas, excessive amount and rate of speech composed of fragmented or unrelated ideas. Assess affect for anhedonia, depressed, lack of feelings or joy in life. Blunted affect, absence of facial expressions, apathy, boredom, or lack of concern, and lack of energy. Sense of self, this is a loss of ego boundaries. In other words, the person is detached from oneself or their behavior. Your textbook has a very good guide on assessment guidelines that you could probably want to review. Remember, positive symptoms are easier to identify, but does not always mean good. The negative symptoms are blunted emotions and are more severe. Many negative symptoms are misinterpreted by others as just being lazy because of the decreased ability to interact with others and to care for themselves. Interventions should be geared toward the patient's strengths and healthy functioning. First, focus on decreasing anxiety and establishing trust. Be honest, keep promises, which builds trust, and be consistent in setting expectations and enforcing rules. Consistency increases trust, and consistent limits provides a secure structure for the client. Ensure safety of client and others by approaching the client in a non-threatening manner. Don't make demands. Give ample personal space to yourself and your patient. This protects you as well as the patient. Oftentimes, with the negative symptoms, the client is unable to meet basic ADLs, so you may have to assist with eating and ADLs. Give positive feedback for client success. Positive feedback for genuine success enhances the patient's sense of well-being and helps make non-delusional reality a more positive situation for the patient. Accept patients as they are, but do not accept all behaviors. Everyone wants to be accepted. Avoid verbal and nonverbal communication that could be interpreted as a threat. Monitor the hallucinations, but do not reinforce them. If the client says, I hear them talking to me, then you should state, I understand the voices are real to you, but I do not hear any voices. Are you afraid? You did not reinforce the hallucinations, but you did assess if the voices are telling them to hurt themselves or someone else. Don't argue or confront the patient. This is a threatening manner and can lead to decrease in self-esteem. Set limits and offer alternatives. An example is give them permission or set limits to do or carry out a task, but offer an alternative to the disruptive behavior. Do not laugh or whisper around paranoid schizophrenic patients. Do not touch suspicious patients. Warn them before if there is a need to touch them. Avoid close physical contact and always maintain eye contact. Do not use humor. This could be misinterpreted in many ways. Reinforcing reality is accomplished by denying, seeing, hearing, and etc. the delusion or illusion, but accepting that you understand that they are real to the person and then focus on other things. It is okay to distract patients' attention from hallucination or delusional beliefs. To deal with associative hallucinations, do not pretend to understand patients' communications when you do not. Tell the patient you are having difficulty understanding them. Word salad and use of neologism makes sense to the patient, but makes absolutely no sense to the nurse. Sometimes you can pick up on themes between the words being used. Nurses and staff experience extreme frustration because of the slow progress of patients with schizophrenia. The sense of frustration leads to burnout for nurses in the psychiatric setting. Expect bizarre behaviors as the illness progresses to the acute phase. Be aware of symptoms associated with the illness, such as the negative and positive symptoms. Explain to the family ways to respond to behaviors associated with illness and what to expect. Teach the family about appropriate medication management because it is often left up to the family to provide the care and to ensure that the medication regimen is adhered to. Make sure to include when to take the medications, the purpose of the medication, and the possible side effects. Remember, milieu therapy is a method of psychotherapy that controls the environment of the patient to provide interpersonal contacts in order to develop trust, assurance, and personal autonomy. This is accomplished by providing for the patient's safety and the safety of others, setting limits, decrease in environmental stimuli, arranging for non-threatening activities, provides distracting activities, and milieu therapy is anything and everything that applies to the treatment. Individual psychotherapy is to help the patient with management of delusions and hallucinations. The therapy focuses on decreasing anxiety and increasing trust. This is accomplished by being honest, supportive, and consistent. Be kind and show human dignity. Help the patient to identify sources of real or perceived danger and ways to react appropriately. Group therapy focuses on real-life plans, problems, and relationships, helps to reduce social isolation and increase a sense of cohesiveness. Group therapy is less effective in inpatient centers due to the amount of stimuli present, more effective in outpatient settings. Behavior and cognitive therapy focuses on reducing the frequency of bizarre and disturbing behaviors and helps to increase the appropriate behaviors. They need clear, measurable goals. Social skills training uses role playing to teach patients appropriate eye contact, interpersonal skills, and posture. Social skills are aimed at improving relationships. Antipsychotics are used to alleviate symptoms, not curative. When patients discontinue medication, psychotic symptoms return and relapse occurs. Each relapse leads to longer recovery time and the possibility that the patient will become unresponsive to the medications. Types of antipsychotic medications are the conventional or first generation and the atypical, which are second generation. Conventional or first generation drugs, these are the only effective drugs in treating the positive symptoms of schizophrenia, those with bizarre behaviors that we usually notice. And they have no therapeutic effect on the negative symptoms. The most common side effects of the extrapyramidal side effects, abbreviated EPS. Nursing considerations and interventions address the EPS side effects of the antipsychotics. First, assess patient's response to the medication and for any possible drug interactions. Monitor the patient on antipsychotic meds for extrapyramidal side effects as shown in the slide. EPS can occur at any time during the medication therapy. So if any change in movement is noticed, the medication should be held and the healthcare provider notified. The medication either needs adjusting or changed. Administer the abnormal and involuntary movement scale, abbreviated AIMS, AIMS, to assess the patient for signs of tardive dyskinesia. Remember, this is not reversible if not caught very, very early. The website for this scale is the website you see in the slide. Monitor and intervene for anticholinergic manifestations. This would be urinary retention, constipation, dry eyes, hypotension, and orthostatic hypotension. Remember, these medications dry a person up. Intervene by suggesting or providing sugarless gum or hard candy to offset the effect of dry mouth. Use saline drops for dry eyes, plenty of fluids, and encourage the use of stool softeners to prevent constipation. And instruct the client to use caution with sudden changes in body positions due to possible orthostatic hypotension. Monitor the patient's body weight for weight gain at each visit. Instruct the patient to avoid getting overheated in the sun and use sunblock due to photosensitivity. Monitor the patient for any seizure activity due to the antipsychotic's effect on reducing the threshold for seizures. Instruct the patient to have weekly white blood cell counts if taking clozapine because of the risk of agranulocytosis. This is a severe drop in white blood cell count, which can increase the client's risk for infection. Some signs and symptoms of agranulocytosis are sore throat, fever, and malaise. Instruct the patient about neuroleptic malignant syndrome, which is rare but potentially fatal. Neuroleptic malignant syndrome produces decreased levels of consciousness, increased muscle tone and rigidity, high fever, hypertension, sweating, tachycardia, and drooling. The antipsychotic should be stopped if this occurs. Symptoms are treated. Antipyretics for fever, muscle relaxants for rigidity, and comfort measures in an intensive care environment. Dopaminergic medications like medications like bromocriptine or Parvidel or dantrolene are muscle relaxants which are used to resolve the increased muscle tone and rigidity. These are the atypical antipsychotics or the new generations of antipsychotics. The advantage of atypical antipsychotics are that they are effective in treating the positive and negative symptoms. The atypical produce minimal to no extrapyramidal symptoms and decrease the risk for development of tardive dyskinesia. Also helps improve cognitive deficits and decrease anxiety and depression. Disadvantages of atypicals tend to cause weight gain associated with additional metabolic side effects, increasing risk for diabetes, cardiovascular disease, and hypertension, and they are more expensive than conventional typical antipsychotics. The atypical antipsychotics are often chosen as first line of treatment for schizophrenia due to the minimal side effects. For patients taking antipsychotics with EP side effects, anti-Parkinson agents can be given, which are used to counteract the extrapyramidal symptoms associated with antipsychotic medications. Anti-Parkinson agents are prescribed PRN for patients taking antipsychotics. Anti-Parkinson's cogentin is used to treat the symptoms of Parkinson's disease and tremors caused by the disease. So it also works for treating the EPS side effects of antipsychotics. It also helps with the anticholinergic effects of antipsychotics. Benadryl is ordered PRN and given for rapid relief of acute dystonia. Dopamine agonists are given to treat Parkinsonism.